Thank you so much, Lisa, and thanks to all of you for joining. I know that your time is short, and I'm hoping that this can be useful for you. I think that it's a fairly intimate group of folks on the phone call, and so I'd encourage you to interrupt with questions. It's definitely not meant to be pedantic. I'll start just by situating and introducing myself and my work. As Lisa mentioned, I identify first and foremost as a primary care doctor. I see adults and children in a federally qualified health center in West Philadelphia, and that is one of my favorite parts of my job and my identity. It really keeps me grounded in the work. In addition, as Lisa mentioned, I am the executive director of the which is a national center of excellence for community health worker research, application, and dissemination. And Lisa mentioned our mission is to improve pop health through the effective use of community health worker programs. We serve this mission through 3 sets of activities. First is research. When we first started doing this work about a decade ago, we really started out asking patients, particularly lower income patients, what they thought made it hard for them to stay healthy, and asked for their advice in terms of what could we be doing differently in healthcare. We interviewed 1,500 or so lower income patients on porches, shelters, hospital bedsides, to really kind of learn their perspectives. And if we don't get to talk about that again later, I just want to highlight that for all of you who are doing primary care innovation in the field, I think this was a critical first step, not only engaging patients in general, but specifically higher risk patients, because their perspectives are often different from the average patient, and they're less likely to have their voices included in primary care redesign. I just want to pause for a quick second. I know that there's a little interference on the line. Can everyone hear me okay?
Sorry, Trey, I had to just unmute myself. Yeah, it's a little bit fuzzy, but I can hear you clearly.
Okay, great. Terrific. So that was some of the formative research that our center led about a decade ago, and we used those patient interviews to essentially design Impact, which is a standardized, scalable community health worker program, which I'll talk more about in a moment. We also did and continue to do evaluative research. So we've conducted 3 randomized controlled trials of the Impact program, and these have all demonstrated fairly consistent results in terms of improved primary care access for patients who work with an Impact community health worker, improved patient-reported quality, so that's CAHPS or HCAHPS on the inpatient side, improved mental health, and then a 65% reduction in total hospital days. These results really translate into a return on investment of about $2 for every dollar invested by a Medicaid payer. And so this has enabled our work to translate from research to actual patient care in practice. We have a direct care program here in Philadelphia, employ about 60 full-time employees, most of whom are community health workers, and we've been able to deliver the Impact intervention to over 10,000 patients, supported by hard dollars from providers, payers, even VA. The third bucket of our work is clearly, that over the past decade, we have learned a bit about how best to serve the needs of higher risk individuals, particularly lower income individuals, through healthcare and primary care, and specifically around how to build and optimize community health worker programs. So we are very busy partnering with healthcare and community organizations all across the country, including payers, providers, retailers, to help build or optimize community health worker programs, and we have collaborations ongoing in 18 states. So with that introduction, are there any questions about myself and my role? If not, we can move on and talk about, potential lessons for you all from your perspective. Okay. Terrific. So I always like to start out with this map, which I'm hoping many of you have seen, but if not, this is from Raj Shetty's seminal 2016 JAMA article. It's a map of life expectancy in the United States, and the story that it tells is that how well we live, how long we live is determined by income and zip code. And when you drill down into any of these hotspot zip codes, you see a story that really kind of highlights the disconnect between what primary care has historically been, which is, you know, a tight kind of within the clinic walls relationship between patients and doctors, focus on the, you know, to some extent prevention, but also treatment of diseases, to what's happening outside of our clinic walls, particularly in those hotspot communities that have lower income or concentrated poverty, or that have faced, you know, generations of social disadvantage. The story of what's happening outside the walls is very, very different from what's happening inside the walls. And this is what healthcare has, over the past few years, really become obsessed with, what we call the social determinants of health. These are the underlying social structures, public policies that shape living conditions and access to money, resources, social connections. And clearly, these factors influence health behaviors and influence ultimate health outcomes even more than medical care and even more than our genes. So given this growing realization, and given the fact that healthcare and primary care specifically is now being financially incentivized to actually improve health outcomes rather than just providing services, there's this growing momentum around social determinants of health type of interventions. Having said that, I think this is a terrific thing. I think the evidence is incontrovertible that social and behavioral and economic factors are important drivers of health that we need to address in primary care. There is a pretty concerning evidence gap in the social determinants of health sphere. Again, I'm going to pause really quickly and make sure folks can hear me okay. I think there's a couple people who may need to mute some background noise. I'm not sure, Lisa, is that just on my end or?
I'm hearing some background noise too. What I think what I may do is just mute everybody and then unmute you.
Okay.
Okay, so I apologize, everyone. I'm sorry. Oh my gosh. Sorry, hold on. Okay, so you can unmute yourself now.
Okay, how's that?
Great.
Okay, hopefully folks can still chat in or find some way to.
Yeah, they can unmute themselves.
If they have any questions. Perfect. So I want to do a quick scan of some of the common approaches that you may be hearing about or experimenting about within your own primary care environment for addressing unmet social needs. The first and probably the most common approach that folks are talking about are screening and referral platforms. These are typically technology-based platforms that screen patients within healthcare encounters for unmet social needs such as food insecurity, intimate partner violence, housing instability, and then make online or telephonic connections to existing community-based resources. The idea is incredibly intuitive. Having said that, when we look at high-quality studies of these types of approaches, there hasn't been a lot of evidence to support this approach in and of itself. It may be a necessary but not sufficient component of a larger social determinants approach, but these programs and platforms in and of themselves, in a couple of studies of Healthify or Health Leads, have had fairly low uptake and very minimal effect on actual patient outcomes. And theoretically, there may be a couple of reasons for this. One is that they're, fundamentally light touch interventions, and maybe high-risk patients need a little bit more than just a one-time informational support intervention in order to move needles like hospitalization, chronic disease control, access to care. There's a limited supply of community-based resources, and oftentimes high-risk patients have already known about these resources and may have exhausted these resources. And then third, these kind of discrete solutions may not actually get to the underlying nuance or complexity of what folks' root causes are of their health condition challenges or their fundamental lack of well-being. There's a difference between addressing somebody's low self-esteem and referring them to behavioral health. So that's just a quick kind of scan of screen and refer, knowing that this is a vast literature and I'm just, doing an overview here. The second approach that folks often have heard of, popularized, of course, by Jeff Brenner and the Camden Coalition, are complex care teams. Now, these are care teams that typically exist in a way that is separate from the primary care infrastructure in many cases. And they are multidisciplinary teams that include a doctor, a nurse, a social worker, a pharmacist, a community health worker. And this care team typically provides intensive, targeted care management, usually to folks who are, I think, somewhat pejoratively termed super utilizers for a specific period of time, and then patients are transitioned back to their primary care practice. Again, there's a lot of face validity to this approach, and it's been tremendously popular, and it's really kind of permeated how we think in healthcare. Having said that, a couple of studies that have come out of care team approaches targeting super utilizers have been negative. To Camden Coalition's credit, they are doing a randomized control trial of their approach, and so it'll be really interesting to see what that reveals. But as of now, there hasn't been the most promising evidence. And some of the theoretical issues may be that, number one, these care teams are quite expensive. There's a lot of fixed costs to having all of those predominantly clinicians that I mentioned kind of on the ready for any given patient who may or may not have those specific types of needs. The other thing is that they're complex. Sometimes patients can end up needing a navigator to navigate their care team. And then finally, they still tend to be clinician-led. And so the focus is, despite being holistic, it tends to be a little bit more clinically oriented. The final thing is, if these care teams are operating in some ways in a parallel universe to the primary care practice, there's a little bit of a problem there because they're working with patients in a way that doesn't necessarily strengthen the underlying practice infrastructure. And there are handoffs that must happen, and potential voltage drops that have to happen after the care team is transitioning patients back into their regular primary care environment. Any questions or comments about these first two domains? Because I know that probably these topics have come up before.
Any questions? If you can, all you have to do is just unmute yourself and you'll be able to speak. Okay, I guess we can go on.
Great. Briefly, there are a couple of other common approaches. So these would be domain-specific interventions, prescribing food, prescribing transportation, prescribing housing. Again, very, very logical, and nobody would argue that a fundamental inequity in terms of actual resources for daily life drives some of these underlying health inequities that we are all focused on addressing. Having said that, again, the evidence for domain-specific interventions has been somewhat disappointing, despite the hype that is in the news, that's often driven, in all of these cases by before and after studies that can be really misleading. When you look at actual credible studies, which typically have, comparison groups, in the best case scenario, they have randomized comparison groups. A lot of these domain-specific interventions haven't really moved outcomes. And again, the theoretical reasons are probably because poverty or social disadvantage, these are ecological problems. They have multiple layers to them. And if you give somebody a Lyft ride share, for example, and expect that to decrease their emergency room utilization, you may be disappointed to learn that there are other problems that actually step into the place of transportation. Whether it be housing or food or intimate partner violence, you haven't only solved one layer of a problem for any given individual, and that may not be enough to move the needle. And then finally, there's intensive nurse care management programs that have somewhat focused on social determinants of health, but sometimes have broader populations. So examples of this would include the Nurse Family Partnership, which is a nurse home visitation program where nurses visit pregnant women all the way through until the first 2 years of a new child's life. And these actually have demonstrated, another example would be the Naylor model of intensive nurse care management for frail elderly patients who are transitioning from hospital to post-hospital primary care. Many of these programs have demonstrated benefit, whether it's mortality benefit, with Nurse Family Partnership, or reductions in hospitalizations with the Naylor model. Having said that, some of these programs have had limited scale just because they are fairly costly. So that is kind of the very quick and dirty scan of the social determinants of health approaches, bar one, which I'm going to delve into in greater detail, and some of the evidence of practice gaps and limitations. This brings us to the concept of community health workers. Where do community health workers fit into all of this? And certainly, community health workers have a clear role to play. Let me start with a definition. Community health workers, as Lisa mentioned, are trusted lay people who share life experience with the patients they serve. So these folks share educational attainment, sociocultural background, language with their patients. Beyond being demographic mirrors, community health workers have a certain personality type. They are defined in the sociology literature as natural helpers. There are people who, after they've done a week of work helping people, on the weekends volunteer at a food shelter. A food pantry. So there's a just high natural altruism there. There is a difference, I think, between community health workers and other terms that you often hear about in this space, like health coaches, care coordinators, case managers, navigators, etc. And perhaps simplistically, I think about community health workers as a noun, and I think about these other terms almost as verbs. A community health worker can coach, she can coordinate, navigate, manage a case, but beyond those specific roles or functions, there is that shared identity with patients that I think has been really well established for creating trust and really kind of having expertise in the real life problems that patients are facing. Any questions? Y'all are making this too easy for me.
Shreya, actually there are a couple of questions.
Oh, great.
And they're coming in on the chat because I made everybody be quiet. So sorry. Jack, I'm going to unmute you and see if you can ask your questions here. Okay, go ahead.
Can you hear me now?
Yeah, we can hear you. Great, thanks.
Okay. In one of your previous slides, you said that there are individual. I'm getting echo.
Yeah.
Are you getting echo?
Yeah, we are. But just go ahead. We can just ask your question.
Individual interventions sometimes aren't that effective, but we have noticed that when you put them as part of a bundle, they make the bundle more effective. For example, the ventilator-associated bundle, there's a bundle of activities for decreasing readmission rates and discharge from the hospital, those kinds of things. So we agree that all those things, even though they may not be individually effective, when you add them to a bundle of activities, that can make the whole bundle more effective. That's one thing. The other thing is the targeted intervention that you talked for super users. It looks like that's the kind of concept behind the seriously ill population part of primary care first that CMS is doing. I've been involved with a PACE program in the past, which was very similar to that. And we did find that it dramatically decreased utilization and improved patient outcomes. So we, from a personal standpoint, we think that that works. I'll remute.
Thanks. I think that's really a good thing to underscore that, many of the trials that I referenced in the previous slide are testing these components a la carte, and so a combination could certainly have different effects. And your point about, your experience are very well taken. One, and I'm not sure of the specific references in your case, there may be, really strong study designs. I will say that there's probably an overconfidence around some of these study designs in the field, largely because, again, the typical way that we evaluate our initiatives in practice are through pre-post studies. And that is expedient, certainly, but the problem with that is that many of those are a little bit susceptible to regression to the mean. meaning that, life goes in these ups and downs. Nothing really remains constant. And when you pick a group of people who are defined by being outliers in some way, whether they have the highest A1Cs or the highest rates of hospitalization, even if you do absolutely nothing at all, but just follow them over time, their rates will improve. And what we are seeing really often in this field actually is that programs are sort of taking credit for that natural statistical law of gravity, if you will. And so that may not be the case in the examples that you're providing. That is something that we see quite often in this field. I have this box in the middle of my slides that says, please move the window away, but I can't seem to do that. I apologize if it's distracting. And Lisa, if you have any suggestions for how to get rid of it.
I can't access it because it's on your on your screen. I could pop up. I can take away your share and just move the slides for you. That might be
okay. Yeah, that's fine.
Okay. In the meantime, there are a couple of other questions. One was whether you have a care team, multidisciplinary care teams, as part of the program that you're assessing.
Yeah, let me actually go ahead and get into, I'll talk a little bit more about that once we get into the program. So I want to move along more quickly so we actually get into talking a little bit more about
it. So
there's an impact.
If you stop sharing, I will share instead.
Okay, great. So while we're switching over the reins, let me talk about community health workers. So we finished defining them. I want to say that this is not a new concept. Community health workers have been around for over 200 years. Predominantly in the developing world. There have been a lot of global implementation science studies of community health worker programs. And they have really allowed us to see that even though community health workers as a concept have great face validity again, it makes total sense that these folks are from communities and they are well positioned to address many of the underlying social needs that we're talking about that drive health outcomes. Actually, many community health worker programs have failed to move the needle on outcomes or be sustainable. And that's quite surprising. And so what we started out a decade ago, we did a really deep dive into this global implementation science literature to understand, well, why have some programs succeeded while many others have failed? And it boils down to 5 key factors, actually. And so Lisa, if you want to, we'll just go to the next slide, which is that picture of the Chinese barefoot doctor program. And I'll just quickly enumerate some of the pitfalls that community health worker programs have hit historically in the past. Number 1, hiring. This is fundamentally a human resource innovation, and so it's only as good as the people who you've hired to do the job. Yet in healthcare, I just put out a Harvard Business Review article about how we hire in healthcare, or how we often forget about hiring in healthcare. We are very obsessed with training and credentialing, and sometimes we forget about the actual hiring practices. And that's the case for community health worker programs as well. There's often, skipping of the hiring step, or, hiring just based on credentials. And that leads to really high turnover rates. These programs have turnover of about 50 to 77%, which is going to be multifactorial, but one part is that it's driven by these lack of hiring practices. The second historic limitation is just lack of standardized program infrastructure. Community health workers are not a model, they are a workforce. And so if you think about how to apply that workforce in a particular model or in a program, there are a number of other decisions and infrastructural elements that need to be thought out. What are community health workers actually doing? How long are they working with patients? What are their caseloads? Who's supervising them? What's the underlying theoretical framework for the intervention model? Who's keeping them safe when they're out in the field doing home visits in potentially dangerous neighborhoods or circumstances? Where are they documenting? Who's assessing performance and how? All of these questions are often, we're dealing with them in fairly cursory ways, actually, in the field. The third issue is that many of these programs have been disease-specific. And even though they can be very effective in their disease-specific domains, for example, there's a number of studies that show that community health workers or peers with diabetes can really be effective at reducing A1C. The problem with that, of course, is as primary care clinicians, we know that patients have multiple comorbidities. And so is a patient supposed to have a diabetes comatura and a peer for their addiction and, a coach for their blood pressure? It just becomes confusing. And so there's a need to have a model that could be a little bit more upstream and universal. The next issue is that there's a need, and a lot of places get into difficulty with balancing the grassroots community-based identity of community health workers with some clinical integration. You don't want to go too far with the clinical integration and have this workforce be totally medicalized, where they're just following the nurses or doctor's orders, doing the things that only the care team wants to do as opposed to the patient, and really just doing conventional pathways of medical, conventional medical pathways like medication adherence or scheduling follow-up appointments. On the other hand, so you do want to have them maintain their grassroots identity. On the other hand, they do need to be plugged in somehow. So striking that balance has been challenging. And then the final issue has just been the quality of the evidence. So we have kind of designed IMPACT, if you can go to the next slide, thanks, Lisa, with these historic limitations in mind. It's basically a standardized model that addresses these core factors. And I think the best way to kind of illustrate how it works is to tell a brief, patient vignette, and then we can go into some of the infrastructural factors and then leave time for questions. So I'll tell a story of a patient, Mr. Brenner, who's a 50-year-old gentleman, like many of the folks that we're imagining in primary care that aren't best served by traditional primary care. He's someone who had a lot of childhood trauma. In his adult life, he was incarcerated, and when he got released, he found himself estranged from his family and having a tough time finding a place to live because he was no longer able to be eligible for subsidized housing. So he began living in an abandoned store without any heat, became desperate, and tried to take his life several times in a one-year period. Every time he was admitted to the hospital, he was seen by psychiatry and social work. He had a primary care provider. He really never made it to that engagement, and he was still kind of stuck in this cycle that we know too well. On the final of those hospitalizations, he was connected with Cheryl, an IMPACT community health worker. She got to know him as a person. She asked him slightly different questions than the social workers and the psychiatrists asked him. One of those questions was, when was the last time that you had joy, that you actually belly laughed? And he thought about it for a moment, and he realized that he hadn't laughed for the past 27 years. And so she asked him, well, what were you doing when you laughed? And he said that he had been bowling with some friends. So as a first order of business, she then, when he got discharged, took him bowling. And that was a very unusual intervention, to say the least, but the effect was fairly transformative. He kind of remembered that life could be fun again, and then was motivated to continue to work with her on some of the more traditional linkages, like getting into primary care, getting behavioral health appointments, finding a job, and he is now, renting a room independently. Is in much better shape. You can advance the slide. Thanks, Lisa. So, I tell that story, and it seems magical, and I think it is, but it was magical but not accidental, because Cheryl herself was someone whom we hired using specialized hiring algorithms that I can talk about in more detail that allow us to identify, hire, and retain natural helpers from the community. And with these hiring algorithms, we've been able to have a turnover rate of about 1.7% annually over the past decade. In advance. Beyond the hiring, the questions that she asked Mr. Brenner, I'm just gonna, is it letting you advance?
Oh, I'm sorry, I didn't.
Oh, that's okay.
Here you go.
Okay, so the questions that she asked Mr. Brenner came from a semi-structured interview guide that is a part of work practice manuals that we've developed for community health workers. So it wasn't an accident that she, asked the right questions and was able to take those questions and work from there to really tailored, patient-driven action plans that she then provided hands-on support with. You can advance. Thanks, Lisa. She documented her notes in an app that we co-developed with community health workers. And then if you go to the next slide, she received really kind of one-on-one supervision from managers, whom we also specifically hired for their capacity to supervise the CHLB workforce, and we trained using our interactive online training platform. You can. So I think just to kind of wrap up, there are a few lessons, I think, from primary care. One is that fundamentally, the primary care model needs to be reimagined in a way that eliminates our walls. You know, we have all heard about the fact that most of health outcomes is driven by, you know, the time that we spend away from the clinical practice. Yet when we think about how we are reimagining and redesigning primary care, we still tend to think from the inside out. So I think, you know, thinking more broadly and starting with that end user, you know, interviewing the patients that you actually are worried the most about, you know, the woman with diabetes who lives under a bridge, talking to her about how she would reimagine your primary care practice probably would yield some really important findings. I think shifting who our healthcare workforce is and how we hire them is critical. You know, again, we are carpenters, and so, you know, we're hammers and everything is a nail. So we tend to think about clinically staffing our primary care practices and having interventions be somewhat clinically driven. That may not actually match up with the underlying needs that patients have that we need to solve if we're going to improve health outcomes. Oops, I think we. I think that it's very important to innovate, and there's definitely not a one-size-fits-all solution. Having said that, I think that there is this growing realization that primary care innovation and social determinants interventions are really every bit as hard to get right as biomedical interventions. And so it is important to at least build upon evidence-based interventions and be skeptical of evaluations that aren't rigorous, because they do tend to be misleading in ways that we've discussed. And then the final piece is really one of the things that's hardest for some of us as primary care providers to fully embrace, but letting patients drive the intervention in a really, really complete way. You know, in the impact model, community health workers ask patients, Mr. Jones, what do you think you need in order to improve your health? And they can say, I need to get a reason to get out of bed in the morning again, you know, let's go bowling, or, you know, I want to start baking bread again because that was something that truly brought me joy, or I want to reconnect with a senior center. These are really out of the box things that sometimes as primary care providers, we're like, what does that have to do with your A1C? And what does that have to do with your, you know, frequent hospitalizations? Like, that does not seem to be the right approach here. Paradoxically, our trials are some of the strongest data that being truly patient-centered actually moves the clinical outcomes that we are all focused on: A1C, BMI, smoking, blood pressure, hospitalization, and quality of care. I know there's probably a lot of questions. I gave a high-level overview, and I want to save some time for Q&A.
Okay, so sorry, I'm just gonna unmute people. There was one. Okay, go ahead, please.
Hi, Palmer Yurikaris in Rhode Island. Thank you so much. It's like, I think what you highlighted, and I'm wondering, you know, is the importance of implementation. And I wondered if you could just talk about the studies that you're doing and kind of how you're trying to evaluate that aspect of things.
Sure. Do you mean, can you say a little bit more about what you mean by that aspect?
So implementation, and I guess I'm thinking about implementation on several care, which is how you identify the folks that you want to intervene on, because that's one piece. And, you know, then, you know, the idea of a comprehensive evaluation, but then, you know, getting into that, I don't know what you'd call it, qualitative aspect of the kind of person that you're hiring and how you're overseeing it and things like that. So those are like at least a couple aspects of implementation. And then a completely different question, but while I've got you, is, you know, we're in Rhode Island kind of beginning really active work with the Department of Health and the whole idea of, you know, the place-based. So you're dealing with the social needs on the patient and family side, and you're dealing with the social determinants on the community or region area, and what work you might be doing with, you know, with that part of it. So two separate questions.
Sure. Yeah, in terms of implementation, implementation science has been foundational throughout all of the work that I've described to you. So just to give examples, you know, qualitative interviews with patients was really the kind of basis for how we came up with the list of traits that we are hiring on. When we interview patients, we ask them, hey, what problems, you know, what makes it hard for you to stay healthy? And they gave us, you know, a 4-page list of answers, including, hey, you know, as soon as I go into my doctor's office, I feel judged and I feel like people are talking at me and not listening to me. So we took every one of those problems and put it into a table. And for every problem, we said, what intervention step would solve this problem? So for the, you know, issue of I'm being judged and I'm being talked at, we said, well, if somebody could really do an open-ended strengths-based interview with patients, you know, when they were meeting them, that could address that problem. And then we added another step, which is what traits would somebody need to have in order to do that step better? And so in order to, you know, conduct an open-ended strengths-based interview, it would help if somebody was a good listener, you know, that they like to listen more than they like to talk, and that they were non-judgmental. So that was something that we would put in the traits cell. And we went row by row, and at the end we had this laundry list of traits that we were looking for. And there were a lot of surprises for what was and wasn't on that list. The things that weren't on that list were letters behind your name. For this particular use case, now nobody's arguing that, you know, training or credentials don't matter for clinical roles, but for a lot of the real life problems that patients were facing, it was more important to have some of these personality attributes. And so then we use organizational psychology based principles, which I don't probably have time to go into, to recruit, to screen people based on their traits, not necessarily just based on their resume or diplomas, and then actually make some hiring decisions. So that's one of the core components, I think, of effectiveness. When you think about implementation science, you know, you often think about, okay, here's an intervention, it works. Why does it work? What are those core components that drive the effectiveness? And, you know, what matters, what doesn't matter when you think about replicating this at scale? Like I said, we are now partnering with, you know, 50 organizations that touch about 200 million individual lives across 18 states. And this will make really rich implementation science. We have funding from PCORI to do a study where we're looking at, you know, I mentioned the core components for impact, but, you know, the way that they are being adopted by the partner organizations that we're working with vary. You know, some of them use our hiring algorithms, others don't. Some of them use, you know, the app and others aren't. And so we're going to be able to see over the next few years what is critical to achieving the kinds of outcomes that we've demonstrated in randomized controlled trials, and what maybe is a little bit more flexible. Second question, you know, broadly place-based and social determinants interventions. I might need to hear a little bit more about that. I think broadly, everything that we're talking about is place-based and addressing, you know, underlying social determinants of health. This community health workers come from, you know, local communities. They serve patients in geographic catchment areas for multiple reasons. Number one, they take that place-based approach because that builds community capacity, because we're then able to match, you know, community health workers' backgrounds with, you know, the predominant backgrounds in that community culturally and socioeconomically. And then also because over time, you know, you're really able to see when you serve 10,000 patients in a 10 zip code area, they start having connections with each other and building capacity in some really remarkable ways.
I guess just quickly, the idea around how you know, so you can do the same issue around, you know, finding housing or developing transportation, but if you're partnering with trying to actually mitigate the social determinants, not just for the patient, but for the population.
Yeah.
What you're doing around that for many approaches with, as I said, like partnering and forming state agencies, collaborating with other organizations that may be serving similar or the same populations, and whether you're doing anything around that.
Yeah, that's a great question. So I always say that I think community health workers are really the power grid upon which broader SDOH interventions ought to be built, because what they do is they work with individual patients. They solve problems where they can through really creative, resourceful ways that may not necessarily be these plug and play referrals, like taking people bowling. That's not a referral that you could make on a platform. But then they are also they are collecting data on problems that they are not able to solve on the individual level. For example, like try as they may, CHWs in Philadelphia are not always able to secure stable housing for their patients. They can try to help patients, figure out a place to stay with a friend or a family member. But if we're talking about, high quality, affordable housing, that's a limited resource. And so I think that one of the things, I'm just going to stop my video for a quick second. I have to plug in. Can you still hear me?
Yep, we can hear you.
So I think one of the things that is really critical is that community health workers and the data that they collect can be used to target macro investments. And so to your point, one of the things that we're doing, for example, is working with the Philadelphia community across all of the different community health needs assessment. And some of our data informs that health needs assessment, and we're able to say, here are the problems in a geographic way across the city of Philadelphia. Here's a housing hotspot, here's a food desert, and these are the places where community health workers are not able to make behavioral health linkages. And that kind of data, I think, can be applied on several layers of policy. Does that answer your question?
Yes, thank you.
You're welcome. And very similar to the Accountable Health Communities Track 3 alignment.
Thank you. Shreya, there's a question that came on the chat. It was a specific tool that one of our colleagues had a question about. So the question is, do you have any data around those who used Healthify as an engagement tool that you'd be able to share?
There is a study that was done on Healthify, and it came out of the Baltimore Care Connect program. It's one of the references that is cited in the earlier slide where I talked about a scan of the literature. I think Chidemba Ibe was the first author, and Albert Wu was another author on that. And yeah, I mean, again, it's one study, but there were fairly low rates of uptake for the Healthify intervention. And there, in that study, there were no effects, I believe, on whether patients were able to actually connect to resources and solve their unmet social needs, as well as health outcomes. So I think that's a study that I know about for that specific platform. Having said that, this has been a common theme for many of these platforms. There are studies that show, particularly in the pediatric literature, that folks are relatively open to being asked these questions about unmet social needs, and it is something that is feasible. But then, there's not a lot of uptake of the resources that are offered, and then ultimately, there's not a lot of change in patient outcomes, whether they be social outcomes or health outcomes. And I think part of the reason for that is that these screen and refer platforms, by and large, the one exception to that I think is Stacy Lindau did some work years ago through a CMS innovation grant, and for her platform, which is called NowPow, and that was a comparison study. It wasn't a clinical trial, but it was a well-matched comparison study, and they did see some effects on resource connection, I believe. So that is my understanding of the literature. A really useful resource is the SIREN Network, the Social Interventions Research Network, led by Laura Gottlieb out of San Francisco. And if you just Google SIREN, they have an evidence library that has virtually every study that you could want that has anything to do with the social determinants of health or social interventions.
Great. So another question came in on the chat, and this is asking you to have weigh in like a vote, it looks like. So in your opinion, since social determinants of health will always be important, which of the 4 lessons of primary care do you think is most critical to drive improved and long-lasting health outcomes?
Which of the 4
lessons of primary care?
And remind me, what are those lessons?
Yeah, I'm not sure what that refers to either, but the person who wrote that is able to speak, Sam? But I guess we could extrapolate to say, if you think about the areas, whether that's, I assume we're talking about.
Lisa, this is Deb.
Yeah, hi, Deb.
One of the slides had 4 points. I just happened to jot them down, and I think it was the lessons that, there it is, right there.
Oh, there we go. Okay.
Oh, got it.
That might
Okay,
be
lessons. I thought you were talking about something more codified than just this slide. So since social determinants will always be a thing, which of these lessons is most critical? Forced choice exercise. Well, first, as is my nature, I will challenge the very premise of the question, which is, will social determinants always be a thing? And I got to tell you, I get out of bed in the morning worried that it may not always be a thing, largely driven by this evidence to practice hype that we're seeing. I think that chances to invest hundreds of millions of dollars to address structural injustice and poverty in the United States, that's a pretty rare thing. And I worry that the appetite for that kind of social transformation will not always be a thing if the early initiatives that you all are working on are not met with true and meaningful success. And so I would just say, there's caution there that this is a really remarkable opportunity moment, that we all kind of have a really high we should have a high bar for our work in this space. Having said that, I think that letting patients thrive would be my favorite of these 4 lessons, both in terms of the design of interventions and within interventions, driving their own care, and within primary care, driving their own care. One of the things that I'm worried about, in primary care and this growing social determinants space is what I call the gentrification of social determinants. There's a lot of new actors, healthcare leaders in particular, who are coming into a space that has existed for a really long time, and there are a lot of conversations that happen in clinical practice settings about unmet social needs, about how to redesign primary care to improve population health. And I often look around the room and there aren't any patient voices in that room, and there certainly aren't the kinds of patients that we are talking about. And so there's a grave risk that all of our best intentions and all of our best ideas are a little off the mark if they're not grounded in the experience of patients. I'll give one example just to make this more concrete. We did a study a number of years ago where we interviewed lower income patients, publicly insured patients, about their experience being a part of a patient-centered medical home. These were all patients of PCMHs. And we asked about, some of the very specific strategies that their clinics were using to achieve PCMH status. And actually, even though the strategies were designed, for example, to enhance access, for these particular patients, they were creating access barriers. So for example, same-day scheduling, right? A lot of our clinics are moving towards offering more same-day slots, and as a trade-off, there's a decreased ability to schedule advance appointments. But a lot of patients, have jobs where it's really hard for them to call out the day of without facing, consequences. And B, in order to get to the doctor's appointment, they need to schedule Medicaid ride services or at least public transportation passes, and that requires a 72-hour notice. And so again, it's a granular thing, but if we're not having patients at the table at all stages, we could be really missing the mark in some of our design.
Thank you. A question came in about around reimbursement and what your experience doing this work at Penn has been in terms of getting payment for the work of community health workers.
Yeah, it's a good and a really timely question. Our model is based on, so the outcomes that we demonstrated in clinical trials, including HCAHPS or CAHPS improvement, enhanced rates of transitional care management visits, and reductions in hospitalizations, those all translate into dollars for Medicaid, regional Medicaid payers, and for our parent health system, which is Penn Medicine. So our funding is not based on state level reimbursement. It's based on contracts, essentially, that we have with Medicaid payers and with and just operational support from the health system budget that is tied to those outcomes. What's happening across the country is quite different. There's a number of ways that community health workers are currently reimbursed. They're largely, without getting into all of the details, through either Medicaid waivers or demonstration projects, or in some cases, they're baked into existing value-based payment models. So that is kind of the current landscape. The only additional thing I'll say about reimbursement is that to the extent that any of you are influential about policy around reimbursement, I have a worry a little bit that community health workers and their reimbursement will become fee-for-service, which is actually the world that we are sort of moving away from. And it could really change the nature of this work, just like it changed the nature of healthcare, to be more about episodic, widgets and, the hours spent on the phone with somebody, rather than truly changing their outcomes in a lasting way. And so that's one kind of concern, is something that we advocate for, is to kind of think about community health workers in terms of just having that be a billable service for a structured evidence-based intervention that is designed to move outcomes, rather than a per episodic rate. The other piece that is related to reimbursement is about CHW certification. Many states, right now, community health workers are one of the fastest growing workforces in healthcare, and that is a really exciting thing. The problem is that there is just great heterogeneity and variation of community health worker programs. So the numbers of community health workers are increasing, but that may not match up with the quality of the community health worker programs. And so in an attempt to streamline this, many states are exploring CHW certification and having that tied to reimbursement, which is a really good intent. The problem is that the way that a lot of states are thinking about certification is, again, tying it to CHW, an individual CHW's training. Did Mary get this approved training course? And that's just a reflection of our healthcare mindset. We're quite obsessed with training and credentials. The reason that it's potentially a problem is that training and training-based certification, there's no evidence to suggest that that's really the thing that drives program outcomes, right? We talked about all of the years of global experience and what that has taught us about the importance of hiring, the importance of supervision and caseloads and, infrastructure and the intervention design, and training may be one of those pieces, but it's certainly not the only one. And beyond that, it's quite burdensome for individual community health workers who often, don't make a lot of money, who may not have, the highest educational attainment, but are really smart, really amazing people. And so the natural helpers, the folks who are best suited for this work, may not be able to jump through that training and certification hoop, and we might be being out the natural helpers. So we at the Penn Center for Community Health Workers are actually partnering with NCQA to develop program standards. So again, this would be for employers who have community health worker program to think more holistically about, hey, are there hiring practices in place? Is there adequate supervision? Are community health workers, being asked to do meaningful work with reasonable caseloads, and really kind of thinking about benchmarking those standards for reimbursement rather than just the individual training. I know that was a long answer, sorry.
No, it's a very important piece of people are looking at this. So we are at the top of the hour now. Shreya, I want to thank you so much for a really wonderful, informative discussion. And I'm glad to see so many people on the line today. Are you okay if I post these slides on our website?
Sure.
Great, thank you very much. And the contact information for the center is right here. Once again, thank you so much for this great presentation, and hopefully people will take these lessons home and start to think about how they can apply them in their regions.
Thanks so much for having me.
Thank you, bye-bye.
Thank you all, that was terrific.
Great.